Welcome to the first of a series of slideshows that will explore the hidden history of anesthesiology and explain how reform of presently prevailing beliefs, habits, and standards can lead to the next great advance in anesthesia theory and practice. This first slideshow will review the clinical effects of CO2 management. Those anesthesiologists who were taught that mechanical hyperventilation is beneficial, as I was, may be startled to learn that hyperventilation is inherently harmful and dangerous and offers no benefits under any circumstances. They may be further surprised to learn that in the forgotten past, CO2 supplementation was an essential element of anesthesia practice as well as a practical and effective therapy for numerous medical conditions. Hyperventilation is abnormal, inherently harmful, and deceptively dangerous. It depletes CO2 tissue reserves, inhibits respiratory chemoreceptors, undermines respiratory drive, and impairs cardiac efficiency. It reduces cardiac output, diminishes tissue perfusion, hinders tissue oxygenation, damages lung tissues, exaggerates nausea and vomiting, inhibits opioid clearance, and exaggerates opioid respiratory depression. In extreme cases, it causes cardiorespiratory collapse and death. All this was understood 100 years ago. I will offer some practical examples to illustrate the occult danger of hyperventilation. The first is shallow water blackout syndrome. Every year, healthy young swimmers accidentally kill themselves by hyperventilating in preparation for swimming underwater in the mistaken belief that this will enhance their oxygen reserves. However, hyperventilation does not enhance oxygen stores, and even brief voluntary hyperventilation can dangerously deplete tissue reserves of CO2 and obtund respiratory chemoreceptors. The swimmer completes a couple of laps underwater and then becomes hypoxemic, but he experiences no warning urge to breathe because hypoxemia itself is painless. Instead, he experiences mild euphoria and literally falls asleep and drowns at the bottom of the pool. When Hewlett-Packard engineers were testing early versions of their capnograph monitors, they discovered that the otherwise healthy polio victims were being severely hyperventilated in iron lung machines. This doubled morbidity and mortality. Anything that depletes CO2 tissue reserves will obtund respiratory chemoreceptors, undermine respiratory drive, and increase morbidity and mortality. The heart-lung machine can easily deplete CO2 tissue reserves, which undermines respiratory drive and increases morbidity and mortality in a manner identical to hyperventilation. Animal physiology is not adapted to altitudes greater than 4,000 meters. More than 200 bodies lie near the top of Mount Everest, where the low partial pressure of oxygen induces hyperventilation that depletes CO2, reduces brain perfusion, and causes unexpected loss of consciousness. It also causes occult brain damage in professional guides who repeatedly climb to the top of Mount Everest. Mechanical hyperventilation during anesthesia rapidly depletes CO2 tissue reserves and paralyzes respiratory chemoreceptors. Hyperventilated patients appear to breathe normally after anesthesia, but their respiratory drive remains unstable until metabolic activity restores normal CO2 tissue reserves and chemoreceptor function. During this vulnerable period, which may last for hours, patients may suddenly and unexpectedly stop breathing if they fall asleep for any reason. Most victims are elderly patients with low metabolic rates who undergo uneventful surgery and appear to be fully recovered from anesthesia. These disasters typically occur soon after they return to their private rooms and receive combinations of opioids and tranquilizers to mitigate pain and promote sleep, whereupon they are left unattended. The problem is thus called the opioid hypersensitivity syndrome, but the true cause is iatrogenic mechanical hyperventilation during anesthesia. Proper CO2 management could eliminate this problem. As we shall see, this phenomenon was clearly understood 100 years ago. Mechanical hyperventilation during cesarean sections depletes CO2 tissue reserves in babies as well as mothers. This causes newborn babies to unpredictably stop breathing and die soon after birth. This is the reason that spinal anesthesia is nowadays considered safer than general anesthesia for cesarean section. Mild permissive hypercarbia during general anesthesia eliminates this problem. Both old and new research has repeatedly demonstrated that mild permissive hypercarbia stimulates respiratory drive, enhances cardiac efficiency, increases cardiac output, improves tissue perfusion, increases tissue oxygenation, protects lung tissue, prevents nausea and vomiting, accelerates opioid clearance, and offsets opioid respiratory depression, prevents cardiorespiratory collapse, and can be used to treat infarction, stroke, pneumonia, influenza, carbon monoxide poisoning, drowning, smoke inhalation, and a wide variety of other problems. These beneficial effects were widely understood and utilized 100 years ago. In awake volunteers, breathing elevated CO2 concentrations causes a frightful sensation that conveys the impression of toxicity and stimulates tachycardia and hypertension. Anesthesia abolishes the frightful sensation as well as the tachycardia and hypertension. During anesthesia, CO2 supplementation increases CO2 tissue reserves, stimulates respiratory chemoreceptors, reduces blood viscosity, enhances cardiac efficiency and cardiac output and tissue perfusion, tissue oxygenation, and opioid clearance, and reduces opioid sensitivity. Clinically, it increases respiratory drive, accelerates anesthetic induction, enhances hemodynamic stability, offsets morphine effects, enhances skin warmth and color, reduces postoperative nausea and vomiting, and prevents postoperative respiratory depression. In contrast, mechanical hyperventilation during anesthesia rapidly depletes CO2 tissue reserves, paralyzes respiratory chemoreceptors, undermines respiratory drive, increases blood viscosity, decreases cardiac efficiency, reduces cardiac output, impairs tissue perfusion and oxygenation, exaggerates nausea, inhibits opioid clearance, and exaggerates opioid respiratory depression. During the early history of anesthesia, carbon dioxide supplementation was used routinely during anesthesia, and physicians used carbon dioxide to treat a wide variety of medical problems, but the medical use of CO2 was abandoned due to fears of CO2 toxicity. In the late 1980s, critical care physicians inadvertently rediscovered the therapeutic benefits of carbon dioxide while searching for better ways to manage adult respiratory distress syndrome. They call it permissive hypercarbia, and they use it routinely as a safe and effective means to optimize cardiorespiratory function and prevent lung damage in critically ill patients in the intensive care unit. But anesthesiologists and other physicians have failed to follow their lead. Anesthesiology professional organizations provide detailed standards for nearly every aspect of anesthesia practice, but they have persistently refused to publish standards for CO2 management. The failure of physicians in general, and anesthesiologists in particular, to re-embrace or even recognize the benefits of hypercarbia despite overwhelming scientific evidence can only be understood in terms of anesthesia history and politics. This brings us to a merciful intermission. Part 2 of this presentation will examine the issue of CO2 toxicity.